Welcome, my friends, to the intestinal ultrasonography group prepared by the EG-BUS, the Egyptian Society for Bowel Ultrasonography. Actually, the intestinal ultrasonography is a great tool to examine the bowel. The reason for this is the benefits given by the ultrasound. It's widely available, cheap, non-invasive, safe, with no radiation, perfect for point of care examination and giving you what to do in the patient at the time of examination. It can be safely repeated and it's a real-time imaging of the bowel. Actually, you are doing yourself ultrasonography of the bowel every day. You are seeing the bowel while you are examining the abdomen, but you are not paying attention to it. An example of this, when you examine the upper abdomen by the probe of the ultrasound, you see the liver, you see the pancreas, you see the vessels, but at the same time, you see something between the pancreas and the left lobe of the liver, that's the stomach. Again, if you are examining from the right side in the mid-axillary line, looking for the right kidney, you can see the gas shadow of the colon. These things are present in every part of the abdomen you examine. However, your eyes are not used to examine these parts. Our rule in this society is to let you look further into these parts, not only to see them, but to examine them very carefully, see the pathology and the normal diseases of this bowel. Ultrasound has more to give. What I mean by this, if you look at the abdomen, actually the whole intestinal tract is just deep to the abdominal wall. The things which prevents you from seeing this is only the skin, the subcutaneous tissue, the muscles, and the fascia. And as you can see here, except for the upper part and lower part of the GIT, the whole bowel is there to be examined. One more thing, you will always find the cecum in this part, you will always find the sigmoid colon in this part, you will find the hepatic flexure here at that part, and you will find the splenic flexure here at that part. What I mean that you have fixed points in which always when you go to these points, you find the things you are looking for. I myself appreciate this very much when I look at the axial scans of the abdomen. I find the right colon very easily visualized, just deep to the abdominal muscles. The outer one, the external abdominal, this one, internal abdominal, and this one is the transverse abdominis. On the other side, you can see the descending colon. In between this and that, and again deep to the abdominal wall, is the small bowel. The abdominal muscles are here, almost the same as here, and in the middle, you can find the rectus abdominis muscles with the linea alba between them. This part, as you can see in the CT, is the fat of an obese patient, and this makes ultrasonography of the bowel a little bit more difficult, as you will see in the future demonstrations. What I need to examine the bowel the right way, I need a good machine, ultrasound machine. A moderate or an old one will not help you in this. You need a machine with a capability of Doppler, and the higher the one you have, the better you will see the small bowel. As for the transducer, we are using the usual curved transducer with 3.5 megahertz frequency to examine the organs and the deeper part of the bowel. However, to examine carefully the layers of the bowel, we always need a higher frequency ultrasonography probe around 7.5. Higher and lower than this is also welcomed in certain parts of the examination. Wherever you examine the bowel, you will find the bowel signature, the 5 layers of the bowel of white and black stripes alternating with each other. Let us go to one by one. The first white one is the interface between the lumen and the mucosa of the GIT. The next one is the deep mucosa, which looks gray or black like this, black most of the time. And under this, a hyperechoic layer, which is the submucosa, followed by the muscle layer, which is always, again, hypoechoic, and then the serosa. And get used to these terms, hyperechoic and hypoechoic, instead of black and white. These layers are not synonymous with the histology. And in most of the time, the most important 3 layers for us are the 3 ones where we measure the distance from here to there, referring to the thickness of the bowel we are going to examine. The reason for that is the upper part and lower part, the hyperechoic here and there, are usually mixed with the surrounding tissues so that you cannot delineate them very much, but you can delineate from the edge of the hypoechoic layer here to the edge of the hypoechoic layer here. The magic number is 3 millimeters. Higher than this is abnormal. As an example of this is the wall and the lumen of the stomach. This is the anterior wall. This is the posterior wall. And let us go through the 5 layers. This is the serosa. This is the muscle layer. This is the submucosa. This is the deep mucosa. And this is the superficial mucosa. The 3 layers I talked about, 1, 2, 3, are very similar to the Oreo used to buy. There has been a surge in the publications dedicated to intestinal ultrasonography, particularly in the field of inflammatory bowel disease. And now, cross-sectional imaging with intestinal ultrasonography, or MRI, is an integral part of the assessment of patients with Crohn's disease, and again in their follow-up and in their decision for treatment. As I said before, there is a surge of the ultrasonography literature, particularly in the field of Crohn's disease and ulcerative colitis, and now the ultrasound is one of the main monitoring devices in patients with Crohn's disease activity, in patients with therapeutic response to treatment in ulcerative colitis, and in particular in ulcerative colitis, the response would be very fast so that you can monitor it by ultrasonography. Again, in intestinal emergencies, intestinal ultrasonography is a very valuable imaging modality. Failure to use this modality is not the thing you would like to do. I myself, I have a dream that in the future, gastroenterologists will use the probe of ultrasonography to listen to the bowel the same way we used to use our stethoscope to listen to the heart sounds. Intestinal ultrasonography Actually, will it change your life and will it change the way you look at the bowel, at the diseases of the bowel? There is a saying that ultrasonography scanning is more of an art than a science. And usually we hear the sentence that says ultrasonography is operator dependent. So we are giving you the tools to paint the ultrasonography future of yourself, but it's up to you to complete this picture. The more you dedicate yourself, the more you use it, the more you follow the progress, the more you follow the group, that will be your way to advance your skills and knowledge in this part. Thank you all, and I'm waiting to hear from you.